to the Sick Society podcast. Today, joining Alexis and I is Kathryn Mannix, who is a palliative care doctor and an author, and we're going to talk about death and dying. And from all the things I've learned from Kathryn, both from her books, but also from her talks, I think we're going to have a fascinating conversation. Kathryn, do you want to just tell us a bit about yourself?
Hi, I'm Kathryn Mannix. I was a palliative medicine consultant in the NHS and in several independent hospices over a 30-year period. I took early retirement 10 years ago now to campaign for better public understanding of dying because I was just so desperate, meeting people over and over again, so frightened of a soap opera or a Hollywood death and just not knowing what to expect. So I've been making good trouble since then, and I've had the good fortune to write a couple of successful books and be invited to write and speak and broadcast quite widely. So I'm sorry if you're fed up of hearing my voice, but I do feel really passionate that we need to understand this better.
Never get fed up of hearing your voice, Kathryn. And she's being a bit modest. She is the author, best-selling author, we should say, of With the End in Mind and Listen, both fantastic books that I would encourage everyone to read. So we're very pleased to have you. Thanks for coming. And I had a couple of questions that I thought could kick us off. So the first was, because you're both doctors, Kathryn, you've spent a lot of time and expertise on dying, but Bod, I'm sure you've seen your fair share as well. So what do you both think is the biggest misconception around death and dying?
Do you mean medically or publicly?
Whichever you want to go with.
Okay, I think that the problem that we share, whether we're coming at this as clinicians or we're coming at it as members of the public, is that we've completely lost an understanding of the process of dying. So we appreciate the process of gestation and birth. We appreciate its phases and stages and roughly what happens when. And we've lost sight that the process of dying very often is also a process with phases and stages. Timing is a bit less predictable than pregnancy, but otherwise it's a biological process. And so because nobody knows that, and those of us who become clinicians are taken into schools of healthcare to be trained how to stop people from dying, we actually don't get educated about the process of dying during medical school, paramedic science, nursing, whatever it is. So now we set up two groups of people who don't know anything about something that they really need to be able to talk to each other about. And it's weird. It's awkward. And we wonder why it's awkward.
Lots of people seem surprised by it and don't seem to have any understanding of what's going to happen. And I think that then creates fear, and everybody thinks that dying is going to be an awful process, where in most settings it's a fairly peaceful, fairly calm process, which, as you say, can be planned for and predicted. So I'm not afraid of dying as an individual because I've seen it lots of times. Clearly, I still want to be here. I still have lots of things I want to do. I'm not expressing suicidal thought here, but as a process, it's not something I'm really scared by. You know, is that just because we changed the way that we do death? It used to be that when Granny died, she was dying upstairs and the whole family lived in the house and everybody had seen her become more and more unwell over the preceding weeks. And then people were used to seeing people die at home. And we've kind of medicalized it as to this is a completely medical process rather than a natural process. That would be my immediate thoughts on the question.
Yeah, I think that's absolutely right. And it's a twofold thing because we are no longer looking after our dying people at home for a huge variety of reasons, dispersed families, more medical interventions that might actually postpone dying on this occasion. So it's worth being in hospital if you want to have a go at that, all of these things. We've become unfamiliar with what was once familiar from seeing it repeatedly at home, so that you could see it often enough to work out what's the underlying process and what's Granny's version of it or Uncle Bob's version of it. But also what people see when they come into hospital is a medicalized version of death avoidance. It's not the ordinary process of dying very often. And so we see decommissioning of life-sustaining treatments followed by a death, rather than this gradual putting out of the lights, as it were, as the body winds itself down towards death.
And one of the things that I find really interesting in how people understand death is that there seems to be this concept now about how it somehow it's failing. Like like death is failing at life instead of a natural sort of, well, we can't live forever. So from the moment you're born, you're dying because you can't live forever. And yet I've had so many conversations in my own research, especially talking to healthcare professionals, where they talk about some deaths as failures. And how I can remember really strongly one of the doctors I interviewed for my PhD of all things, and he was talking to me about cancer patients, and then he said, there's this tree that the family of one of my patients planted at the hospital, and I can't walk past that part of the hospital. He said, it's been 30 years and I can't walk past that part of the hospital because it feels like a failure. He said, I've had loads of patients since and loads of patients before, but that was a turning point for him where death was this failure. It seems like such an odd concept because it's not like there's a contest. That you can't live forever. It's impossible to live forever. I mean, yes, it'd be nice to live in relatively good health for as long as you possibly can. I mean, we would all like that and wish that on others. There isn't some secret formula that if we cracked, we'd all be 1,002 and I'm perfectly happy. So I wonder too if there's a societal issues around how we understand what death means. As Catherine was saying, it is a natural process, but also there aren't winners or losers in death.
Yeah, it's interesting, isn't it? It's part of the medical model, I suppose, is that what maybe we're trying not to lose in hospital, and it is particularly in hospital. I suspect that you wouldn't get that same response from general practitioners, for example, is we're trying not to lose this particular episode of care. We recognize that this patient is a mortal being, but we'd rather they didn't die on our watch of this thing. But I don't know. We've got an eminent physician in the room.
Mm,
What do you think?
I don't feel like that. I mean, I suspect there are generational differences. I've been qualified now for over 35 years. I've seen a lot of people get better, and I've seen a few people not get better. And if I've done everything to the best of my ability that I think is appropriate in that setting, I don't feel that I've failed. I feel that I've tried to make a difficult process as easy as it can be for that individual and their families. I don't know how much, Catherine, you've been involved with teaching medical students, and Alexis the same, about when you're young and you've not really experienced death before, suddenly it does become this big thing. And also there is a slight blame culture permeating our health services that if something doesn't go right, somebody must be to blame. It must be somebody's fault. Yeah, sure, things go wrong in healthcare, sadly, quite often, but it's rare that somebody will die as a result of it. But the vast, vast majority of deaths that I see have occurred as part of the natural process. And that's why when I'm having conversations with people who are nearing death and talking about things like do not resuscitate orders, which is a big hot potato, you get a range of emotions. Say, of course, I want to be resuscitated. And I know that the resuscitation process is pretty brutal, and that if I was to have a cardiac arrest now and somebody was going to try and resuscitate me, I'd like that very much. Thank you very much at 58. But I also know that it would do my body a huge amount of damage, and that I would need to probably be in ITU for a period afterwards, and I might just about come back to being normal and the person I am at the moment after that. But generally, if I've got anything else wrong with me, it's not likely. So having those sort of conversations, what people's expectations are about what we can achieve with medical intervention, which I would include resus in, I think is something that we're guilty of shying away from as healthcare professionals. I think we need to be much more open and honest about what we can do and what we can't do. But people always look for the positive, don't they? The number of times I see it diagnosed many, many people and help people through the cancer journey a lot. And I know people who've got metastatic disease who clearly are not going to survive this. And some of them still have this idea that there's going to be a magical cure somewhere and they just need to keep looking and they'll eventually find it. And I find that heartbreaking because I think, well, you're wasting what precious time you have left trying to find something that you're never going to find. And you just need to make peace with that and make the most of what time you have.
Yeah, I think it's really interesting. I think when I was a more junior doctor, because I qualified in the 1980s, I think failure was a motif. I think, though, that there is a resistance to noticing the onset of a terminal phase or a reluctance that very often is personal and mirrored a little bit by choice of specialty. And very often it's also to do with the amount of personal investment in helping somebody to emerge from something really, really difficult. So you think about hematologists. Hematological malignancies very often present in extremis, and they rescue people from the brink of death using treatments with really high toxicities, and yet with great confidence that they will regain command of this bone marrow. They will reduce the size of these lymph nodes, that the numbers will sort themselves out, and they almost always do. And it's quite remarkable. And so they kind of keep coming back again and again at each relapse, at each transformation, with another recipe for meeting a patient in extremis. And so they're late to recognize the approach of death. And also for their specialty, the only way of reducing the chaos in the bone marrow very often is palliative chemotherapy until very, very late in the illness. And so they have an investment, a personal investment, a very long-term relationship with a patient who's got immense trust with them because they were dying when they met this doctor, and this doctor saved them.
Yeah.
I think it's prevalent across oncology, but particularly in heme-oncology. I used to work at my job principally was in liaison palliative care in a big teaching hospital. Our esophagogastric surgeons would spend 18 hours on their feet digging in somebody's chest and abdomen to filch out a tumor and mobilize upper gut and join things together that have got no business being joined together anatomically. Their patients would routinely meet the palliative care team as part of their introduction to their treatment, not because they were going to die, but because the rapid symptom control post-operatively is the express way to early chemotherapy, radiotherapy, or both, which is the route to cure for those people. So part of treating them with curative intent was very early intervention by the palliative care team in terms of symptom management post-operatively. Great use of a palliative care team, by the way. And they're really highly invested in their patients doing well. Invested this huge amount of time, expertise, exhaustion, emotional labor, as well as physical labor in surgery and in immediate follow-up. And so they are pained and distressed by symptoms that might indicate metastatic disease after all of that has gone on. So I think that it's easy to be judgy about people not noticing dying, not diagnosing dying, not raising the possibility of dying early enough. But I think we also need to recognize that it's because we're humans and we're emotionally invested in these humans we serve doing well, getting better, being cured. I think Rod's right, though, that we do manage a lot of people who've got long-term conditions that will eventually be life-limiting. And it's really unusual to discuss that at diagnosis or in the early and middle phases of that condition. Should we? Should we be making people a little more aware from the get-go that this might kill you? Or is it kinder not to discuss that early on? Or is even the notion that it's kinder not to discuss that early on the same as the paternalism that I saw as a house officer when we didn't tell somebody that their first demyelination episode in the neurology ward I worked on was probably going to be their sentinel signals of multiple sclerosis. They weren't told that until their second or third episode.
Well, I wonder if that comes back to this abandoning of the idea that death is natural and part of the natural course, because if we talk more about it, then we're more aware of where it comes from, and perhaps there's less scariness around it. And that kind of leads me to the second question I had for both of you, which is, what do you wish people knew about death and dying?
You don't have to do it in hospital, but actually, when it comes, many people end up coming to hospital because that makes it often easier for the families and the relatives because we're not well set up in the community to look after people dying at home, and it's something that we really, really need to invest in. So people always say, I don't want to die in hospital. Many people will say, I'd much rather die at home. But actually, dying at home needs a huge investment from the family. You need a really good GP, and you need really good local community palliative care services. And some places have that. And there are some fantastic GPs around who are really comfortable with that. But many places that isn't the case. And then there's some crisis and somebody calls an ambulance, and the ambulance teams are put in a difficult position, and they will often then take someone to hospital because that's what they're told to do. As someone always said to me, no one's ever been sued for taking somebody to hospital, but they have been sued for not taking someone to hospital. So, and I can understand if you've got a relative that you can see is distressed and then suddenly starts gasping for breath, and you suddenly feel that you're out of control and it's really awful, you call 999. Not so much answering your question in a direct way, but it comes to the list of things that we need to get sorted in this country and probably many other countries, is a really good way to manage dying at home, such that everybody knows what's happening, everybody has understanding, and everybody is supported to do so, if they want it.
Absolutely agree. And then picking up your point about it's going okay, and then something changes and breathing changes, and everybody is frightened about that. And yet, breathing changes are part of the process of dying. And so, in answer to Alexis's question, what do I wish people knew? I wish they knew what agonal breathing sounds like. I wish people understood that a person whose breathing starts to change towards their very end of life is dying safely, is doing ordinary dying, is deeply unconscious. Brainstem breathing is released when the brain loses consciousness. They are not bothered by this. We are bothered by it because it's weird. It sounds obstructed because they're not clearing the back of their throats. People are traumatized by their misinterpretation of it. They hear moistness. They tell me that my father drowned, my mother choked. There was water welling up from his lungs. Now, sometimes they're watching people dying with left ventricular failure, and it may in fact be quite a watery end. But usually they are misinterpreting something that is innocent and normal, but unusual and unknown.
Something I was most struck by in all the work that you've done around death and dying, Kathryn, is a talk you did a while back, and you were talking about a doctor who sort of taught you some things around death. But it's stuck with me, and that was you say something along the lines of, you'll breathe in and you'll breathe out, and that will get slower, and then one day you'll breathe out and you won't breathe back in again. And I think there is something around us understanding that this is all a normal process because we're so attached to the signs of life. We have this joke in my family with my kids. If it sounds like one of them's choking, I always say, "Are you alive?" And they have to say, "Yeah, I'm alive." So that I know if you can speak, you're not choking, right? And so we're sort of always on high alert, I think, especially if they're for parents, that the breathing is happening as it should, and yet we spend no time talking about this, right? And until actually I listened to your talk on this, I hadn't ever really thought about what breathing would sound like at the end, or what breathing would look like at the end for someone. And perhaps that's because I've been lucky enough to not be there when someone's been dying. But and then I had to have this conversation with my mom because my grandfather was dying, and she was there, and she was saying, "Well, but it doesn't sound right, and, what about this and what about that?" And I said, "No, he's fine. He's got a nurse there. He's been sedated out of his own request. He's comfortable, but this is what this is gonna look like moving forward." And I had to repeat that with other people, that same kind of conversation, that this is what death looks like, and it's almost like we need to teach this. Like, we need to teach it in school or something. I know that maybe that sounds morbid, but we need to really raise awareness, I think, of what regular dying looks like. If we don't, what it means is it kind of colors people's opinions and approaches to other ways of dying as well. And if you don't understand what regular natural dying looks like, then how do you understand what decisions you'd like to make, what care plans you'd like to put in place, what you would or would not like to have happen to you at the end.
Absolutely right. You can't make an informed decision about your care if you don't know what it is that you might be going to need or what it is that you're going to be asking your family to provide for you. In fact, whether that's your relatives or your family of choice. So we need to understand it, and we need to understand it before we're facing it. We might need to be reminded when we're facing it, but we need to have understood it in advance. And that's the model of midwifery. We educate people during pregnancy so it's not all a surprise on delivery day. And then we remind them on delivery day that this is that thing that we've been talking about.
Here's a hard cutting question. So do you think we should talk about these things at school?
Yeah, I do. Now, Alexis warned me to think about what I might want if I was the Secretary of State for Health, but actually I want the Secretary of State for Education.
Okay.
Right? We have life cycle education in school, except we don't, because we don't talk about death. We don't talk about dying, and we should be integrating it all the way across the curriculum. I'm outraged that we're teaching CPR in Key Stage 4 and 5, but we're not teaching those kids that 9 people out of 10 will die. So when they have a go and their person dies, they'll carry the weight of that.
Yeah.
So we need to think about death as the end of every human life, every guinea pig's life, whatever, and the process of it. Now, the last time I talked about guinea pigs was actually in Derby, and Bod was in the room. I said, all schools should have guinea pigs and we should watch them rear their babies and we should keep them till they die. And at the end, somebody came up to me and she said, I'm a Macmillan nurse in Nottingham. My husband is a vet and he tells me that school guinea pigs have the longest life expectancy of any pet. Because when they're not well, they go to live at somebody's house and they have special medicine that sometimes changes the color of their fur. What can we do if we're going to pretend that death doesn't happen? We can't expect our medical students to have receptors for the information about the process of dying unless they've been given it by us at medical school or they've been given it during their formal education before then. And we know we can spot really early the medical students who've had personal bereavements. They carry themselves in a different way and they have an interest in end-of-life care and planning and being able to be with people, not just do things to people, which is a really important part of transforming our medical model from being doers to being workers with.
So we had to go through this quite early with my daughter. So when she was in nursery, really, really sadly, one of the nursery managers, her child had cancer and died. And I think they were about 9 or 10. And so she was off for a long time, and they explained why she was off, and my eldest was old enough to understand that. And when the member staff came back, she had a locket that she wore that had a picture of her child in it, and my eldest would ask to see what's in the locket. And so they would talk about, this child who'd passed away, and the nursery worker's way of explaining it was that they were still here, they were an angel, they could see everything that was going on, and they weren't very far away. And that was fine until my eldest started saying, "We don't have to worry about if I die because I'll still be here." And I was like, "Okay, let's talk about that a bit more." And she said, "Well, I'll still be here. I'll be an angel, and everything will be exactly the same except I can fly." And I was like, "Okay." She's like, "So it doesn't matter if I look both ways when I cross the road." I was like, "Oh, it really matters when you look both ways when you cross the road." And we had to have this really quite nuanced conversation for a 4-year-old about death and the beliefs after death, and then also quite sternly, like, look both ways before you cross the road. And what's really interesting is that she's carried a lot of that with her. And I noticed that her understanding of death is more nuanced as a result. So she's sad when we've had, unfortunately, a fair few family deaths in the last couple of years. And my mother in law is terminally ill right now. But my daughter's able to understand some of that because we had to have those conversations really early on about what death means and the reality of whether there is an afterlife or not. And, no, it won't just be like you have wings and everything else stays the same. which is quite important, right? Because when they're 4 and 5, they're starting to learn whether they need to be risk adverse. And I didn't want her just waltzing out into traffic thinking it was fine because she'd come back with wings. My point for this very long and slightly hilarious story is that if a 4-year-old in nursery can grasp these concepts, then there are ways for us to teach this across the curriculum at an appropriate maturity level.
I think you've probably highlighted one of the difficulties, which is the kind of metaphysical belief structure that is superimposed on the fact of human mortality and is a huge consolation to some people and a huge annoyance to other people. So, we'd have to think about, I think it's probably secondary school level where we're talking about humans dying. And one of the things we would talk about would be the metaphysical constructs around that and why they matter to the people that they matter to, so that we don't diss them because we're respectful about them. But we can have tree leaves falling and dying, and we can have bugs dying, and we can have pets dying at primary school level and talk about the biology of death and leave it to families to deal with. Has my hamster grown wings and gone to heaven or not? Because I think it very much depends on which branch of which sect of which great faith you belong to, where that hamster might be.
So I went to Catholic school until I was 15. And unless you've gone to Catholic school as well, you cannot believe to fathom the detail with which we learn reproduction at a very young age. The detail of all aspects of reproduction. We even had a book, it was called Family Planning. That tells you a lot, doesn't it? And we started reading it in reception. I know this sounds a bit crazy, but I think we could replicate something like that, because we never learned about death and dying, but we learned all about, I mean, I was a 6-year-old and I knew everything about eggs, sperm, reproduction, of, menstrual cycles, ovaries. I could say fallopian tube. I also knew all the sinful ways that we shouldn't come together and blah, blah, blah. But they tackled it and we could handle it. And so there is something there, I think. And you're right. If we start with guinea pigs that die or goldfish that die, then that eases us in. And I think children are able to understand that. I can think of the pets that we've had since we've had kids. My kids have handled it sometimes better than I have, actually. Our cat passed away a couple of years ago and I was basically in floods of tears for weeks on end. My daughter was kind of okay with it. It is something, and it definitely would be a step in the right direction of this. I guess we're all on team understand natural death, aren't we, in this particular episode? And I think it would be a step in the right direction.
But understanding what everybody else understands about their own mortality and what their belief systems are is really important. So if you believe that you're going to heaven and you're going to live for eternity, then you should not fear death, because that sounds to me quite a nice life compared to current living in this country for many people. So I sometimes I struggle to understand why people fear death so much when they express strong beliefs about what happens after death. But it makes it much easier for me to then manage families and expectations if I understand what people's belief systems are. But it adds a completely different nuance. And I think you do have to kind of separate the mode of how someone dies to then what happens afterwards, because otherwise it just becomes too complicated. And also you then end up imprinting your beliefs or unbeliefs on other people, and that's not fair, that's not right. So it's how we as healthcare professionals support people through the dying process. You have to be very careful you don't bring your own problems to the party. So Alexis must not bring her guilt and her problems of a Catholic upbringing to that.
Yeah, I have to say I carry no Catholic guilt, so don't worry. All I brought with me was the music from that religion.
Most of us will become parents at some point in our lives, and with parenthood comes a flood of new questions and worries, like, will my baby ever sleep through the night? When will I feel like myself again? And why on earth is their poo that colour? So much of what we hear about pregnancy, birth and raising children is built on myth, rumour and outdated advice. That's where the Science Baby podcast comes in. Hosts Dr. Layla Battison and Dr. Kim Bartholomew are science communicators, first-time mums, and unapologetic nerds. Each episode, we explore the evidence behind common parenting advice, bust some myths, share surprising facts about you and your child, and help you navigate this extraordinary, exhausting stage of life with confidence. Find the Science Baby podcast wherever you get your podcasts.
So I want to ask then, I've noticed twice now in this conversation about death and dying and being dead, that one of us is using the expression passing away. Alexis, would you like to say something about that?
I hadn't even realized I was doing it. So that's a really good point, isn't it? And, often when people talk about death and they say the D word instead of death, and we have all these euphemisms, right? So you can pass away, you can go to eternal slumber, can be at peace, all those types of things. I hadn't really thought about it. But you're right. I mean, you have to kind of name the beast, don't you? And the more you say death and dying, the more it becomes just part of the conversation.
My wife gets a bit annoyed with me about this because I go on about when people use a euphemism. So I think passing is I can manage, but when people say, well, they've gone for a long sleep or whatever, I get really, really annoyed, and I say, well, they're pining for the fields. I think because we don't, talk about it in an honest way, I'd say, death is death. I think it actually causes lots of problems.
So I had lots and lots of correspondence from people who've read, particularly with the end in mind. Sad rather than angry, but bewildered. Why didn't anybody tell me that my person might die? So they were in hospital. They told me that their oxygen levels weren't very good and they were giving them more oxygen, or the kidneys weren't great and they were going to have to give them more fluids, or there was something not right about the rhythm of the heart and they were changing the drugs that they were using for that. But I never understood that they might die. And then they died. And so I wrote in with the end in mind. I can't remember the quote particularly, but something along the lines of, we have to be able to explain that people are sick enough to die. What's happened is that particular phrase, which was not what I intended we would say to a patient, has been picked up as, and as Dr. Kathryn Mannix says, we must say the person is sick enough to die. But it turns out that it works. And that families are very grateful that, we're doing everything we can, but you need to understand your dad is so sick he might die. Turns out to be something that helps people to be on the same page as the care team. And nobody minds if you're sick enough to die and by your own heroic strength, or possibly something that the hospital team did, you don't die. Everybody's a hero if that happens. But to not be able to do the things that matter most, because we're still hoping that this person will somehow turn around, and therefore to be robbed of the opportunity to say things, to be sedated, to be put into a scanner so that you'll lie still enough to have that brain scan to see where your bleed is, for example, without somebody saying this might be the last time that your person is awake enough to talk. Is there anything you need to say before we give this injection? We've got to really start to think about how we enable not just the patient, but the people around the patient who will be affected by their death to walk alongside that process so they're not stunned, horrified, unprepared, traumatized, because that's a public health issue. And we're practicing medicine with one patient in mind. Well, we've got a public health responsibility around the village around that person.
And it's a really emotive time. I remember when my mum died. So my mum died almost 10 years ago. She had dementia. She was in a nursing home and she had mixed Alzheimer's and multi-infarct dementia. So she had a succession of strokes, which in some ways was a blessing because things happened fairly quickly. And I saw her as she was dying, and I was absolutely bereft. I knew exactly what was happening, but I was really, really floods of tears, and I'd not had a meaningful conversation with mum for, a year, simply because of her dementia. So I think that it's also important to remember is that families can be emotional, not because they don't understand what's going on, but simply because they understand the finality of the moment.
Yeah.
And if you love somebody, you're going to be affected by it. However, I think trying to reduce the surprise level of what's happening is part of our jobs. And it's, I mean, I really like the phrase "sick enough to die," and I use it. Just to go back a bit, Catherine, to something you mentioned earlier, I think what I look after in my inflammatory bowel disease clinic, after a lot of people with a long-term condition, and very rarely, it can turn into something more sinister, or they can have a severe flare that can result in life-threatening illness, and or they can develop cancer on the background of it. But when I'm first talking about it, I never mentioned death. But over time, over years of knowing somebody, you could then begin to talk about, that people will ask the question, is this going to kill me? And I'm going to say, no, not right now. But there are some risks associated which we can talk about in the future. But no, you don't need to worry about that right now. Again, I think it's having the confidence and the experience. And as a doctor, it's like all things. To be good at it, you've got to practice it. And I think we need to help our medical students be able to come up with coping strategies about how you're going to talk through this with the patient, how you can talk through this with the family, and also how are you going to manage that internally. Sorry, just going on here, but I can remember you talk about esophagogastric surgery. So my first job was in thoracic surgery in Norwich as a houseman, and we had a patient there called Paul who had esophageal cancer, and he had heroic surgery, but sadly got complications afterwards and died. And in retrospect, he had an awful tumor, and things were very much stacked against him. But that was the first time one of my patients had died, and I can remember sobbing my heart out for a brief. I'm macho guy. I thought I could cope with all these things, but it has a direct impact on us as healthcare professionals. So I think supporting each other is also important. And I think it's really important for me as a trainer when I've got people in my team, showing them how we can talk about dying with patients and families is as important as talking about other medical treatment options. So yeah, so I just hadn't thought about Paul for many years. So that's been something that's been worth doing.
Yeah. And I think that's really important what you're saying, because we carry a little graveyard inside us, all of us. And some of them have names, and we remember the names of their families. And some of them, we remember episodes, and some of them, it's a smaller imprint. But this isn't without its consequences for us as human beings. And I think we choose our medical disciplines according to the rewards and our tolerance for the difficulties. And one of the rewards for me is getting end of life care right. And I probably would have been a very happy hematologist, which was the original direction I set off in. But I've been a much happier palliative physician. But the great thing about doing liaison palliative medicine was that I was doing that alongside the equivalent of BOD and those other colleagues in a big hospital, where there's a little bit of confidence boosting by the palliative care team coming to join you, perhaps for some of the patients, where it's trepidatious, where the family dynamics are perhaps a bit more challenging, where the symptom management is outside the expertise of your particular team. So I wouldn't expect to be doing probably nausea and bowel management at a palliative care level for BOD. But, I might come along to help with pain or breathlessness, for example. But on the respiratory ward, I'm not going to get consulted about breathlessness, but there will be other symptoms that I might be consulted about. But very often what we're bringing isn't symptom management at all. It's a kind of backup, second opinion, ethical opinion, just telling you you're doing a great job. Yes, I'll give you a second opinion. My second opinion is I can't fault what you've done so far. You might want to tweak that, but actually you're doing great. You haven't missed something. There isn't something here that you should have done 6 months ago and haven't. Sometimes in a morbidity and mortality meeting, we might then think about what we might have done 6 months ago and didn't. But it's not helpful to talk about that at the bedside of a dying person.
Well, it's interesting. So we spent a lot of time talking about education around death is really important from the very get-go. It sounds like there's also something around training or support for those people who spend the most amount of time around death and dying. So healthcare professionals, for them to feel just as comfortable.
Well, the thing is, everybody's got unwelcome news as part of their portfolio. We have colleagues who have to tell people they'll never be able to bear their own children naturally. We have colleagues who have to tell parents that their child is never going to grow up to be as other children are. Those are devastating pieces of news to break. They lead to bereavements of a different sort. So I think what we've got to learn is how to be comfortable enough to tolerate our own distress when we're in the presence of and trying to serve well people who are very distressed, not just by dying and death, but by the gap between what they expected life to be and what life is actually dealing to them.
There's one thing I'd like to sort of touch on, and that's hospice care. And what do we do about hospice care and palliative care services in the UK moving forward? You can now be Minister of Health because they've been a reshuffle. You're no longer Minister for Education. And you're getting parliamentary questions from your backbenchers telling you that they've got friends who have got relatives in hospice care, but they've also got friends who can't access hospice care. So, how do we improve palliative care in the UK?
I think this is really tricky, and I think what I'm going to say is probably not going to be a very popular response. I think that when there was no palliative care and it was impossible to change the trajectory of cancer care, which is what Dame Cicely was addressing when she first started trying to turn this tanker, doing it outside the NHS, building a separate building, bringing people out of the NHS and changing trajectory that way was the only way that she could establish it. But that's become the model, and it's not an affordable model. And we can fundraise to build buildings, but buildings that have to be staffed and lit and heated, and there needs to be payroll for everybody who works there. There are no economies of scale for providing multiple small hospices across the UK, but that's become the ideal solution in a lot of the public's head. There are other members of the public who live, like where I do, in the middle of the great wildernesses, where wherever you put a hospice is going to be in a centre of population. And round here, there are many more sheep than people. And wherever you put that hospice, it's going to be 2 buses away from most people in most villages. So we need a more dispersed, at the bedside of the people who need care model that visits them where they are, whether they're brought into hospital, whether they're in residential care homes, whether they're being looked after at home. And that way, one whole level of costs has disappeared. Why is it not yet incorporated into the National Health Service? Well, it's not incorporated into the National Health Service because it's expensive, because the staffing ratio in hospices is very different from the staffing ratio in hospitals. And the way that I've seen staffing ratio change over my 40-year career is that we used to staff for care, and I feel that more recently we staff for custody. And that really troubles me. So we need to think about what's the expertise set that we want to provide that currently is being provided by hospices. Is it the holistic, from early on in the illness engagement of a palliative care service that's thinking about physical and emotional symptoms, family dynamics, social losses, spiritual concerns? Or are we looking for a nice place for people to die in? Because a hospice is a very expensive way of providing excellent nursing care. And we can provide excellent nursing care at a fraction of that cost in many other places. But if what we want is a multidisciplinary team to come in and work alongside other medical teams to strengthen their ability to reduce the symptom burden and enhance the quality of living for a person who's in their last months or years of life, then why are we separating that out from the rest of the NHS and requiring it to be financed by people running jumble sales? I think we've got some hard questions to ask ourselves.
There's something there too around how we value death and dying. And if we are working on with an unsustainable model like we have with hospice, what does that tell society about what we think death and dying is? Or what, or I say we, what what policymakers think death and dying is and how they value that compared to other processes that we go through as well.
Yeah, I think it's partly that. And I think it's partly that in the public imagination, being able to die in a beautiful place where the staff are angels is very important. And yeah, I've worked in some wonderful hospices and the staff are fantastic, but I've met people who are just as professional and just as loving and just as compassionate everywhere else in the NHS as well. The thing that palliative care specialists have got when they're not employed by the NHS is time. Time is a really important one of their tools. So we have to start to think about, what are we asking our palliative care people to do? My consultant contract in a big NHS hospital did not allow for training time. And yet I could have helped many more patients by training other doctors and nurses if that could have been included in my portfolio. But no, I had to have my direct clinical care and then my supporting professional activities in the right ratio. So we need to rethink what we ask palliative care professionals to do, because I don't think that all of the care, particularly for physicians, is about direct clinical care. I think a lot of it is about modeling, teaching, training, supporting, encouraging, so that care that is being delivered, for example, by the team that Bob leads in his hospital, is enhanced at every patient consultation by every member of that team who know that they've got a palliative care set of professionals for backup if they need it. But most of the time, they won't need it. All we're doing is supplementing the skill set and the tools that they're already taking to every consultation in clinic and at bedside. What do you think, Bod?
No, I'd agree with that. But I also think the trouble is that because we are reliant on the charity sector so much for end of life care, is that many politicians will say, well, that's something that we don't have to pay for. So that's another cost saved. So they're not willing to think about investing what would be, as you say, quite considerable sums of the NHS budget to try and get a different model going. I also slightly worry as cost of living price goes up and hardship becomes a bigger issue. Charity shops may struggle to get enough funding in to keep hospices going, and the hospices are shutting, or they're certainly having to shut beds in places. And it's a reflection of our sick society. Just to quote the podcast, we need to, I think, have a much more long-term view about how we support people to die in the kindest and most appropriate settings.
Yeah, I think that's absolutely right. And it involves a super investment, really, because if we were to phase out and redeploy the funding that currently is used by pretty hospices who serve 5% of dying people in the country, then we would need to have a parallel arrangement in place before we could step back and step down that arrangement. I've worked in wonderful hospices and I wish them well, but I wish them funding that makes it possible on a continuous basis. And that means that they need to be integrated into the health system that we're running as a nation and not running along on a wing and a prayer.
Well, just like so much of what we talk about on this podcast, it comes down to the right kind of funding, the right kind of policy, getting the right people in place. And death is no exception to that, actually.
So I think the thing that I would like to talk about or explore with you is those CPR conversations.
Bod and I wrote a newspaper article about that many, many years ago during the pandemic when all those do not resuscitate letters were being sent out by GP surgeries. And people were worried that they were opening up letters that said that they or their grandparents or their mother or their father weren't valued enough to be saved and their lives wouldn't be saved. We thought we might try and clear that up. I'm not sure if we did or not.
I mean, the pandemic is probably the wrong sort of comparator, because at that stage we were dealing with an illness that we didn't understand completely, that we didn't have the resources to deal with, we didn't have effective treatments for. And we were making, and it wasn't necessarily me making those decisions, the ward that I was helping to staff and run in the pandemic was already defined as a non-escalation ward. So that meant that patients who came to us, somebody had already made the decision that they were not going to be suitable for ventilation and they're not suitable for escalation to ITU. So if they deteriorated, despite everything we would do and that we had at our disposal, then they were probably going to die on the ward. And it was a really, really hard time. But I think that CPR decisions sometimes need to be made in a hurry, and sometimes, and normally, most times, can be made with proper conversations and proper thought. And as I talked about, an understanding of what the CPR process involves. And it doesn't necessarily mean it's all or nothing. So you can say that, you might want fluid. So my dad is a clinical biochemist, and he's quite clear he doesn't want anybody jumping up and down on his chest, but he is quite clear that he wants people to manage his sodium levels in a particular way because he doesn't want to have the issues that having either a high or a low sodium cause. And I think that's brilliant. So you can have conversations with people about what they want, what they mean by resuscitation, because resuscitation covers all sorts of processes. I think there is a lot of stuff about do not resuscitate orders. In my trust, we use something called the respect form, which is a way of having discussion and a framework to have discussion with the patient and their families about what they would want. And when you talk to many people who are in the late stages of their life, they don't want a huge amount doing to them. They want to be comfortable. They want to be able to spend time with their families, and they don't want to be in pain. And we can manage that. And when I explain the stats of CPR and jumping up and down and doing a full CPR process with a Lucas device and all of that, they say, well, no, I don't want that. And I probably wouldn't want that, in the fairly near future. However, if you're faced with somebody who suddenly deteriorates, and I had this 3 years ago, I was cycling to work between Christmas and New Year along one of the dark roads around Derby. And there was this car pulled over, and there was a guy there. I thought, "Ooh, what's all this happening?" And I was more worried that this guy was trying to rob a bike or something. But it turned out it was his son. He was there trying to flag people down. And despite it being a fairly mainish road, there were no cars. And his son was giving CPR to his mum, who was in her 80s, in the car. So what do you do? He was doing a grand job. He was doing everything right. But I came in and gave him a rake and carried on. And then we spoke to the ambulance team, and eventually the ambulance team came along. And in that setting, that's right, because it's come on a shock and people should have that chance. But I wonder whether they had had the conversation with her at any point in the previous year to say, if you were to have a cardiac arrest, what would you want us to do? And again, that's a societal thing. We don't have those hard, difficult conversations with our families. My family are very clear what I want, but then I'm lucky because I know what it involves.
So it is a societal thing, but it's a societal misunderstanding as well. And TV has a lot to answer for death generally, but CPR in particular. I did read a paper a few years ago, which was a rather nice comparison of survival of CPR in UK hospital dramas compared with American hospital dramas. So 80+% of American dramas, they survive, where it's only 60% in UK dramas, but it's nothing like the 12% of actual survival of cardiac arrest. So I think that we've got ourselves into a bit of a tiz about things in a variety of ways. The first thing is I think we have confused CPR and resuscitation, and we need to reclaim CPR as chest compressions and where we've got the wherewithal, which these days will only be in hospital, rescue breaths, because everything else is an addition. So fluids may be part of fluid resuscitation, but it's not part of CPR. The Resuscitation Council has changed what's included in our definition of CPR in the UK, and now we're different from Australia, New Zealand, and North America. So that's interesting. The next thing is that our junior doctors treat the conversation as though it's a consent procedure. If your heart stops, do you want us to restart it? Whereas what the law says is this is a medical decision. We offer a treatment and the patient has the right to decline it. But if it's not an appropriate treatment, we don't offer it in the first place. So and we've got that now, haven't we, from the Court of Appeal or from the High Court. So to be able to say to somebody, you're really, really sick and we're going to try and put things right. And there are some things that we can do and other things that we won't be able to do. One of the things that we won't be able to do is restart your heart if it stops. So we won't be doing any of that pressing on your chest stuff. And I just want to reassure you that everybody around here understands that about you. So we're not going to do that terrible, difficult thing to you. You're safe. This piece of paper is your safety certificate. It prevents anybody from making the mistake of trying that out. Or, you know what, things are pretty bad. And one of the things that might happen is we might get to the stage where your heart stops. And there's a procedure that we use that isn't terribly successful, but sometimes it is. It's very robust. It's got quite a lot of difficulties with it. But we could try it if you didn't mind. It's up to you. At that point, it's consent because we believe it's medically relevant. But the difficulty we've got is so many hospitals that have that within 1 hour or within 4 hours, resuscitation status would have been clarified. And it bounces unexperienced junior doctors into having the wrong conversation about CPR.
Yeah, I'm amazed how many ward rounds I do where you've clearly got somebody in front of you that is dying and no one has had a conversation about how do you want these hours to go? How do you want us to help you and support you through this?
Yeah.
The patients know generally, and if they're so sick, they don't care and they're not aware of it. So it's then as much trying to manage the expectations of the family as well, because they suddenly think that if we call the crash team, Uncle Jimmy's going to be fine. And we all know that's not the case. They're hard conversations, but that's not a reason to give it to the most junior member of the team, nor to defer it.
No, we should be modeling it. It's a senior conversation, isn't it? And it's a really, really, really important conversation. And something to help families understand is that there are two situations in which somebody's heart stops. The heart stops first is a cardiac arrest. The body is full of oxygenated blood and organs that are doing their best and are working reasonably. Or there's dying. There's the process of dying during which a variety of changes will happen and eventually breathing will stop. And a few minutes after that, the heart will stop. Last, it's not a cardiac arrest. Why can we not recognize this person is not having a cardiac arrest? This person is going to die. Why do we need to trouble this situation at all with a CPR conversation and a certificate? We've lost permission to talk about dying. And the ubiquity of the DNA CPR certificates or respect form or whatever else it is we're doing is a symptom of that bigger ill.
So it's about bringing back those conversations as well, not just relying on a form to say, oh, we've talked about this, but as you said, having the time to have those kinds of conversations, because that little bit of nuance makes a big difference to someone, but it takes time. Well, I think that's a good place for us to stop the podcast for today. Thank you very much, Kathryn, for what's been a really interesting conversation about death and dying, and I think hopefully a bit of a template to show that you can talk about death and dying. It's important to talk about death and dying, and that maybe we'll get a few more people talking about it with those around them because they've listened to this. So thank you so much for joining us today. We really appreciate it.
Thanks for inviting me. I've enjoyed it.
This has been a Haunted Mouse production. Cut that out.